Welcome to the Fascia-Informed Therapist podcast, designed for health and wellness practitioners interested in fascia science. I'm Amy Mayer, occupational therapist, practice owner, author, and educator with more than 30 years of experience using fascia techniques across many settings. Each episode brings practical insights and thought-provoking conversations to help you expand your skills and better serve your clients. Let's get started. Hi, it's February 7th, 2026, and this is another edition of the Fascia-Informed Therapist. Today we're talking about a tough topic. We're going to talk about childhood sexual abuse and chronic pain as an adult. We're going to talk about two different studies, both systematic reviews, one from 2023 and one from 2024. But first of all, why am I choosing this topic? I'm choosing this topic because childhood sexual abuse is not rare, and it affects us as practitioners. With recent news, such as the Epstein file release, it's brought a lot of renewed attention to how profoundly wrong and damaging this abuse is. It also exposed a familiar and very troubling pattern. Survivors' stories are scrutinized, their names are being circulated, their privacy compromised, and while past systems and our current system of power continues to shield these perpetrators from full accountability. This matters because when we fail to listen to survivors or when we treat their suffering as collateral damage, especially in pursuit of headlines, we reinforce the very conditions that allow abuse to persist. Childhood sexual abuse does not end when the abuse stops. It lives on in their bodies, nervous systems, and health outcomes, even decades later. We are clinicians and body-based practitioners who are already working with the long-term consequences of this trauma. Often we don't even know that it may be the source. The research is clear that childhood sexual abuse is linked to chronic pain in adulthood, not because their bodies are broken beyond repair, but because the nervous system adapted to survive the overwhelming threat these survivors experienced. And their nervous system doesn't know if that threat may return, so they are always on. The purpose of this conversation is not to re-traumatize, because I know there are people that listen to this that likely had this experience. Sensationalize, not trying to capitalize and perpetuate anything that's going on in current events right now. Just bring it to our attention that it's important to us. And we're certainly not diagnosing anything or anybody with what we're talking about today. We're just trying to shift the focus back to where it belongs, towards understanding, respecting, and caring for these people who have had this experience in their childhood. It's a separate conversation when we're talking about what happens to people as an adults in this arena. We're going to just focus on children today. Grounding our work in evidence and compassion, we can reduce the stigma and offer a safer and more informed care and make appropriate referrals when needed. Most importantly, we can help the survivors understand their symptoms in a way that restores their agency, their dignity, and their choice. So I said earlier, probably some of you who are listening have had this experience, and if you have, I'm sorry for that. The statistics out there are, in the United States, exposure to childhood sexual abuse, or we're going to use CSA. I hate to abbreviate it because it's important to be able to talk about it and say it out loud. Rates of exposure to childhood sexual abuse by the age of 18 in the United States are 26.6% for girls and 5.1% for boys. And I'll include a reference for that. That's roughly 1 in 5 women and 1 in 10 men. This is a common thing. This is a common thing. And I know there's people outside of the United States that listen to this podcast, and thank you for being here. Over 1 billion children, half of all children in the world, are exposed to physical, sexual, or emotional violence or neglect each year. Got a reference for that one too. When I was a young person, I was not aware of any of my friends going through anything like this, but it's highly likely that many of them were. And I think about my tiny little class of 39 kids, which were over half were girls, and that's a lot of them that were probably experiencing something. I had no idea. Today I have a much wider, more diverse circle of friends, and friends who trust each other and get into deep conversation. And now I know many women, and I even know one man who experienced sexual abuse as a child. And this has been very, I'm hoping I can keep my emotions together, but clearly I cannot. This has been very eye-opening for me to learn this. And I'll talk about this later, but in my practice as well, I ask about this because and you'll see why it's so important that we do. And so I've come across many clients who have had this exposure as well. But when I just think about my friends and how many of them have told me about their experiences, some in detail, and it's so hard to listen to, and being able to connect that with what they're experiencing in their bodies today is an interesting thing to see as a practitioner. So I'm sure all the news headlines that are out there right now, the emails that we can go read ourselves, the pictures and videos we can go see ourselves, or we're seeing on social media, it's got to be re-traumatizing for all these adults who experienced this as a child. In large population studies, childhood sexual abuse is rarely a single event. It's often part of a broader pattern of adversity, of abuse. And the research shows a clear dose-response relationship where multiple adverse experiences significantly increase the risk of chronic pain and disability in adulthood. And in these studies, they talk a lot about the ACEs study. And if you're not familiar with the ACEs study and you're a practitioner who treats people with pain, this would be something good for you to be aware of. You should also probably take it yourself, since, like me, I know many adults who have experienced all kinds of abuse as a child. I didn't have those experiences, and I'm grateful for that. But as I said, I know many people now who have all different kinds of childhood abuse. So the Adverse Childhood Abuse Experiences Assessment, or the ACEs for short, it's a brief, standardized screening tool developed to identify exposure to significant stressors and trauma during the first 18 years of life. It was originally created through large population health studies to examine how early adversity influences long-term physical and mental health outcomes. The assessment typically includes questions about direct experiences or things the children happen to their own bodies, such as sexual abuse, physical abuse, emotional abuse, and neglect, as well as indirect experiences, things related to household dysfunction, including exposure to domestic violence or caregiver substance abuse or mental illness in the home, incarceration of a household member, or even parental separation. Each category is counted once, producing a cumulative ACEs score that reflects the number of different types of adversity experience rather than severity or frequency of any single event. And so there's been lots and lots and lots of studies looking at scores on the ACEs, or your experiences of abuse, direct and indirect, as a child, and how that correlates with adult illness of many, many, many different kinds. When we look specifically at people living with chronic pain, rates of childhood sexual abuse are consistently higher than in the general population. This suggests that clinicians who specialize in helping people with pain, like us, we are already working with these survivors, whether we know it or not. This is why we, in my clinic, Mare Wellness, we include a question in our evaluation about past trauma. We let the client know that if they're uncomfortable answering, that's okay, but we let them know that there's a correlation between past abuse and pain. If clients are not comfortable talking about it during the evaluation, they will often bring it up later and start asking questions about it as they start feeling more comfortable with us and more trusting of us. Not everyone with chronic pain has a history of childhood sexual abuse, and not everyone who experiences childhood sexual abuse develops chronic pain. But the overlap is large enough and consistent enough that it deserves the attention, it deserves our attention in our clinical practices. So let's talk about, before we start talking about the studies, let's talk about the types of chronic pain associated with childhood sexual abuse across the literature. It's most consistently associated with persistent, non-tissue specific presentations, often classified as central or nosoplastic pain, which is a type of chronic pain that arises from altered pain processing in the nervous system, and there's no clear evidence of any kind of tissue damage or injury. And this is a type of pain I see a lot in my practice. There's not a specific injury that happened to the person. It just came on slowly. Now, it doesn't mean that if it comes on slowly, there's an automatic look back to childhood sexual abuse. Rather, that's one thing that can begin to tell us there's something going on, that this person isn't resilient to other things. I also look at, much more benign things like chronic postural issues, or how they're exercising, or sedentary lifestyle, and things like that. So here's a list. Here's a list of what the literature associates types of pain that can be associated with childhood sexual abuse. In the musculoskeletal and widespread pain category, we've got chronic widespread pain, fibromyalgia, myofascial pain syndrome, chronic neck and shoulder pain, chronic nonspecific low back pain. I almost included a study on childhood sexual abuse and low back pain, but this podcast would get very long if I started getting into specifics. But you can go look up any single one of these. If your practice specializes in one of these, you should go to PubMed, go to Google, go wherever you go to start looking for your research and drill down into any one of these. Chronic pelvic pain, vulvodynia, interstitial cystitis, bladder pain syndrome, irritable bowel syndrome. In the headache category, we've got chronic migraines, chronic tension type headache. In the general category, we have higher pain intensity and persistence, greater pain-related disability, movement-evoked pain disproportionate to tissue findings, poor correlation between imaging and symptoms. These patterns are important for us as fascia-informed clinicians because they commonly present, as we said, without a clear injury, yet with marked body-wide sensitivity and threat responses. Okay, let's get into our first study. So this study has 9 authors, it looks like, and it's in 2023. It's called Adverse Childhood Experiences Associated with an Increased Risk of Reporting Chronic Pain in Adulthood, a Systematic Review and Meta-Analysis. This was published in the European Journal of Psychotraumatology. So this is, as I said, a systematic review and meta-analysis. I'm going to read about the method here. They included observational studies assessing associations between direct ACEs and, as I said, our childhood sexual, physical, emotional abuse or neglect alone, so direct ACEs alone, or in combination with indirect ACEs, witnessing all those other things we talked about. So the associations between those and adult chronic pain, which they defined as greater than 3 months in duration, and pain-related disability, so activities of daily living limited by chronic pain. 57 studies were included in this meta-analysis, and they stated that the study quality was generally good or fair. So from the study, I'm going to read several bullet points I pulled from the study. Individuals exposed to direct ACEs had a 45% higher odds of reporting chronic pain compared to those with no ACEs exposure. Risk increased in a dose-response manner, with the highest risk seen in individuals reporting 4 or more ACEs. They noted significantly increased odds of pain-related disability for sexual abuse. Findings suggest ACE exposure is associated with the most common and costly chronic pain conditions, including back and neck pain and other musculoskeletal disorders, which account for the highest total healthcare spending compared to other health conditions. And just before I started this, I was reading another study that talked about the lifetime cost of care for these people. I wanted to get this done, so I didn't pull all that in here, but it's phenomenal. It's phenomenal. It's not just repercussions of pain, it's also, there's a financial outcome for these people as well. Childhood neglect also predicts a flattened cortisol profile in adults, which in turn predicts elevated daily pain and emotional symptoms. Findings support the need to broaden healthcare provider understanding of the associations between ACEs and chronic pain and adequately prepare them to provide trauma-informed care pain management. Trauma-informed care emphasizes physical, psychological, and emotional safety and creates opportunities for patients to rebuild a sense of control and empowerment. Different subtypes of child maltreatment are correlated with another, which makes it difficult to extract the impact of a specific type of maltreatment with an outcome variable. The accuracy of self-reported ACEs is also uncertain. Nonetheless, due to the hidden nature of ACEs, global data suggests self-reported childhood sexual abuse is actually 30 times higher than what's reported, and physical abuse is likely 75 times higher than official reports. That's a lot. That is a lot for us to think about as practitioners and reflecting on, because what we said earlier is we're likely, especially if you're not asking about it on your intake or eval, whatever you're doing based on what type of practitioner you are, you don't know about it. And then there's also they may not tell you about it. And then there's people who have experienced it, but I mean, it could be 30 times higher than what the reports say. So it's a good idea for us just to make sure we're providing trauma-informed care. And that way, if these people don't want to tell us, for whatever reason, we're still providing an environment that can be empowering and feel safe for them. And we know when we do that, we're going to get the best possible outcomes. And it's trauma-informed care is good for everybody. Okay, Article 2. We've got 4 authors on this one. It's a 2024 study, Childhood Trauma, PTSD, and Complex PTSD and Chronic Pain, a systematic review. And this was in PLOS 1 is the journal. I'm not sure what that acronym stands for. Okay. Given the recent introduction of complex PTSD within the diagnostic nomenclature, the aim of the present study is to describe associations between childhood trauma in relation to PTSD and chronic PTSD, or complex, not chronic, complex PTSD, and pain outcomes in adults with chronic pain. So they looked at 13 studies, and the populations that they primarily were looking at were female. Okay, what the review says about CSA. When compared to other medical conditions, studies found higher childhood maltreatment rates and severity in individuals with chronic pain, in particular with regards to neglect, sexual abuse, and emotional abuse. Sexual abuse was consistently overrepresented in chronic pain populations compared to controls. CSA was associated with higher pain sensitivity, greater disability, and increased likelihood of PTSD and complex PTSD symptoms. So it's a shorter study. Okay, so why is asking about abuse, why this belongs in a fascia-informed evaluation? We've touched on this. Based on this literature, including a question about childhood abuse, is clinically justified. It's not intrusive when you can do it gently and thoughtfully, and you have some rationale behind it if people ask. Because the type of intake that we do, it's very, very, very thorough. We have a typical evaluation, which is an hour and a half, and that does include some treatment time. But then we recommend that our clients who may consider themselves complex, we have a complex evaluation that's 2 hours. And that way we have a lot longer to do our evaluation, and then can hopefully get some treatment time in our evaluation visit as well. But that is one of the questions that we ask. And I will tell you, when I first started asking about that, it made me uncomfortable. And then when I started really educating myself about all this years ago and learning how to ask it and bring it up in a way that wasn't offensive, it feels more necessary and important to me now than it ever did before. But we have a lot of clients who they don't understand why we want all the information that we want, but it's all puzzle pieces that when put together helps us figure out what's going on and what may be contributing to their experience of pain. So evidence-based reasons to include this in their history is that chronic sexual abuse as a child or childhood sexual abuse is associated with pain amplification, not just psychological distress. Chronic pain often reflects as a chronically heightened threat state rather than ongoing tissue damage. Understanding the trauma history helps explain the disproportionate pain responses that some people have. And it is so interesting to me how even some people respond to pretty significantly to the gentlest of touch, when they have no imaging or anything else or injury that should indicate a problem in the tissues. Poor response to purely biochemical interventions, fluctuating symptoms tied to stress, emotion, or context. How this supports your role. And again, we're not diagnosing trauma. That is not, at least it's not my role as an occupational therapist to diagnose. But we can collect a lot of information that helps us better understand who the person is. We're identifying risk context that helps us guide what we do, guides our pacing. We might go a whole heck of a lot slower when we go to put our hands on somebody, or the first time we're putting our hands on somebody, we might be sure that they're not laying face down and cannot see what we're doing. Maybe we start face up so they can see us, see where our hands are going. They don't have to be surprised when we touch them. It might inform us the depth of pressure, or where we start on their body, how much pressure we give, and making sure to be very clear about what to expect in the treatment session and what it might feel like in their body. It might make us think about what we ask them to wear, how we cover them. Identifying this risk also helps us think about, do you have a mental health practitioner in your back pocket that you can refer to? When we understand the risk, it helps our educational process so that we can explain things better to our clients and help them understand there may be a connection here that needs to be further explored. So here's a suggestion. Here's how you might say it. Is it okay if I ask a general question about stress or difficult experiences earlier in life, knowing you only have to share what feels comfortable? We ask because there is a clear research link between childhood trauma and pain as an adult, and the information can help guide our decisions about your treatment. It can be as simple as that. You could probably drill that down even shorter if you wanted to. Okay, here's some other things. There's no direct proof that childhood sexual assault causes specific damage in the fascia. There's no evidence that fascia is a primary part of what's going on here, but we do know that based on other studies, we can start making a link. It was the last podcast that I did that was on Houston's theory about how stress translates to organ dysfunction based on chronic stressors. And she was talking more about the chronic stressors in daily life. She didn't reach back into childhood when she's talking about her 6-step theory. But when we know somebody has that kind of underlying condition that puts them in a threat state, when they're dealing with the daily stressors, they're going to react more strongly to them. And Houston talked about how that cascades down into the cellular level and how that changes the body's normal rebuilding process. And that constant threat is that constant inflammation. There's not a stop to that where everything stops and the fibroblasts start to rebuild. If you haven't listened to that one, go back and listen to that one. And then we also have Dr. Schleep's studies on mental health and how it translates to tension in the fascia. So we can, even though nobody's really put all this stuff together out in the literature explicitly, I think Dr. Schleep is, it's there. And these people are coming to us regardless. And the more we know, the more we can help. We also have to keep in mind that most people aren't presenting with one variable. Our clients show up with a lifetime of injuries, illnesses, accidents, surgeries, stresses, sedentariness, poor lifestyle habits. We have to look at the big picture. And what I've talked about many, many, many times in the last 70, I think we're on 80 now, podcasts, is we have to look at all the things that are affecting their experience of pain, and if we can improve their baseline, we can improve their trajectory of healing. So we have to look at everything in the big picture. That's why our evaluation is so long, because we want to know all these things. We want to know the big picture, because they, just like fascia connects everything in the body, all these things are connected to affect one's experience of pain and one's experience of healing. So we also need to keep in mind that there are many people who have experienced childhood sexual abuse and don't have pain or loss of function. But this does not make their story of sexual abuse unreliable. Okay, before we go, let's talk a little bit about education. How do we take what we know and educate our clients on this connection between their childhood sexual abuse and what they're experiencing now as pain? And I wrote down a couple different scenarios of how you might explain that. And I can put these, I'm not sure where I'm going to put these, because I'm not doing the full-on show notes yet. I might get there when I can dedicate myself full-time to this, but I'm not there yet. So I will find out where I'm going to put it, and probably back on the website. We'll see. Okay, so here's a couple different scenarios or what you could potentially say, and I just want you to think about it. Or you can come back to it and to this and write it down. I want to share something that might help make sense of what you're experiencing. You're always free to take this in or set it aside. We know from a large body of research that experiences of high stress or trauma early in life can affect how the nervous system develops. When someone grows up in an environment where their body has to stay on high alert to stay safe, the nervous system learns to prioritize protection. Your survival system is incredibly intelligent, but if it never gets the signal that the danger has passed, it can stay tuned up long after the threat is gone. Over time, that can show up as pain that's persistent, widespread, or feels out of proportion to what we see in the tissues. This doesn't mean the pain is in your head, and it doesn't mean your body's broken. It means your system has adapted to keep you safe, and it may not have had the chance to recalibrate. Part of my role is to look at pain through this wider lens. That includes the body, the nervous system, and the lived experience. When we understand that connection, it can reduce confusion and self-blame, and it helps us choose care that feels safer and more supportive. If anything we talk about here brings up questions or feels like it would be better supported by another professional, we can absolutely talk about referrals. You don't have to navigate this alone. Now, my clients often really like something a little more scientific. So if we turn that dial up a little bit, it might sound something like this. I want to explain something we've learned from pain science that often helps people understand their symptoms more clearly. When a child is exposed to ongoing stress or trauma, their nervous system has to adapt quickly. The brain and body learn to stay alert, scan for danger, and respond fast. This involves stress hormones, the nervous system, and the parts of the brain that process threat and pain. During development, those systems are especially plastic, so when the environment is unpredictable or unsafe, the nervous system can become calibrated towards protection rather than recovery. Years later, even though the original danger is gone, the pain system may still be set to a higher sensitivity. Signals that would normally be filtered out can be amplified. Pain can persist even when tissues have healed, imaging looks normal, or nothing structurally wrong is found. This is not a flaw or a failure. It's a result of a system that learned how to survive under difficult conditions. The pain is real, it's biological, and it reflects how the nervous system is functioning, not damage in your body. Understanding this opens up more options for care, can help us focus not just on the tissues, but on helping the nervous system feel safer, more regulated, and less reactive over time. If you need something really quick, it might sound something like this. For some people, early experiences of stress or trauma are part of why their nervous system learned this pattern. For others, it may be injury, illness, or prolonged stress. Either way, the pattern and pathway is very similar. And that little statement right there might just get them asking questions and, spur a conversation. So to wrap up, I chose this topic primarily due to the release of the Epstein files and how pervasive the problem of sexual abuse is, and how casually this information is being dealt with. No plans to further investigate anyone. And that just feels incredibly shameful to me. We're talking about childhood sexual abuse, but we also said that that's rarely does one type of abuse not have another one around it. They don't often occur alone. And when I think about all the trauma that's being incited on families with children and families with the current approach of ICE, this is trauma. This is trauma to those kids and families. If this work needs to be done, why can't it be done with responsibility and compassion? And just today, I read an article about a woman who was taken when she was going to the grocery store to get diapers for her infant, leaving her 16-year-old and infant daughters home alone. They had no idea where their mother had gone, and the infant was being breastfed. That is trauma. That's trauma, and that trauma will stay with them, affecting them physically and psychologically through their lifetime. And the research supports this. And something that I said earlier from our 2023 study, over 1 billion children, half of all the children in the world, are exposed to ACEs each year. The estimated past year prevalence of ACEs was 44% in high-income countries and 59% in low and middle-income countries. And I guess as long as I'm reaching into some politics, but all this abuse stuff, it's not politics. It's just being human and being compassionate for other people. But we're going to talk about it. And I alluded to this several weeks ago when I got on the NIH website and they said that it was no longer being funded. That was during the very lengthy shutdown that we had. But now we know that $2.3 billion has been taken away from medical and health related research. And we as practitioners should be raging. If all that other stuff isn't enough to get you raging, that should get you raging. And I will put in a link to a wonderful article in Science News, which is an independent journal site. They've been around since 1921. And you can see they have a wonderful graphic in there of where the money is being cut from. And at the same time, all that money is being cut, a lot more money is being spent on increasing ICE, increasing around $75 billion over 4 years. What is going to net us a better outcome in the decades to come? Health-related research or removing people from our country? Something I think about, and I think we'd be better served by, and I'm not against removing people that are criminals, that are doing bad things, but we've got a lot of those in our country who are American citizens, and we could circle back to the Epstein files. Okay, and I recognize that some people are going to disagree with me and think that I shouldn't be talking about this kind of stuff here, but I don't care. I think all of this affects us directly and the people we serve. All this affects you and I and the people that we serve. And when I became an OT, I had to read an oath. And while I was faculty at Creighton University, we had every student that went through, they read that oath when they were brand new students in their professionalism ceremony, and they read it again at graduation. And I'm going to read you just a portion of it. And this was the commitment to ethics. In keeping with the high ethical and moral standards, I will seek to be receptive to what those around me have to teach me, be committed to scholarship and the lifelong pursuit of truth, and be dedicated to building a human community of justice, respect, and mutual concern. You've been listening to the Fascia-Informed Therapist Podcast. Be sure to subscribe so you don't miss new episodes. And if you'd like to go deeper, check out my continuing education courses, both online and in person. You can find them at fasciainformed.com. Thanks for listening, and I look forward to next time.